program for the South Africa. In the next few minutes, we'll talk about specific anti-cancer immunotherapy and monoclonal antibodies. Okay, so first of all, we need to know how can we fight cancer cell. So we have many modalities to treat the cancer cell. Maybe with surgery, maybe with chemotherapy, maybe with radiotherapy, hormonal therapy, transplant therapy, target therapy, hyperthermia, and finally, immune therapy. So what is the immune therapy? So as you know, after many years of using the traditional chemotherapy with a lot of toxicities, a lot of side effects, a lot of morbidities due to the toxicity of the chemotherapy, it was a time to think about how can we use the natural immune system to fight with us against cancer away from the traditional chemotherapy. So the immune therapy is a biological therapy that helps our immune system to fight the cancer. So this is a fight between the immune system and the cancer cell. The immune system tries to hit the cancer cell, and on the opposite side, as a defense mechanism, we can find the cancer cell try to find different defense mechanism to escape from this immune system. Maybe by genetic changes that make the cancer cell less visible to the immune system, maybe by creating a specific proteins on the surface to turn off the immune system, or maybe by changing the surrounding media around the cancer cell to escape the mechanism of the immune system. So the immune therapy, it is not only one type of therapy. The immune therapy, simply we can define the immune therapy into major 5 different types. So checkpoint inhibitors is a type of the immune therapy. T-cell transfer therapy or CAR T-cell is another type of the immune therapy. Monoclonal antibodies is another type of the immune therapy. There is a specific vaccine targeting the cancer cell, which is called the treatment vaccine, is another type of the immune therapy. And finally, there is another medications. This medication has a primary action, which is totally away from our target, but also it has a secondary action, which is enhancing the effect of the immune cell therapy against the cancer cell. That's why it's called immune system modulator. So in the next couple of slides, we'll talk specifically about each type of the immune therapy in couple of slides. So as we mentioned, we have major 5 different types of the immune therapy. Now we'll talk about the immune checkpoint inhibitors. So in a very simple way, what is the checkpoint inhibitors? Normally, the checkpoint like a brake of the car. So normally the car is the immune system going very fast to attack the cancer cell. And as a defense mechanism, the cancer cell has an arm. This arm can touch the brake of the car to make it slow down. So this is the mechanism, the defense mechanism of the cancer cell against the immune system. So this is the checkpoint. So the checkpoint like the brake of the car. So the car or the immune system had a brake, and the tumor cells had the arm that touch the brake, make the immune system or make the car very slow. That's why the cancer cell escape from the immune system. So what about if I inhibit this brake? I prevent the arm of the tumor cells to reach the brake of the car. So if there is no brake, there is no slowdown of the car. So the immune system or the car will go very fast to hit the cancer cell. So this is the idea of the checkpoint inhibitors. So we are inhibiting the brake of the car or the brake of the immune system. If there is no brake, the car or the immune system will go very fast without any slowdown and will hit the tumor cells. So here we can find the tumor cells, and this is the arm of the tumor cells. And this is the immune cells, which is a T cell, and this is the break of the tumor of the T cells. So if the arm of the tumor cell touch the break of the T cell, so the T cell will slow down and it will not affect the tumor cell. But if I cover this part or I cover this part, so there is no touch of the brake of the car, there is no slowdown, the tumor cell will go very fast to destroy the tumor cell. So this is the inhibitor. So the inhibitor maybe cover the arm, which is anti-BDL1, or maybe cover the brake of the T cell, which is anti-BD1. So either anti-BDL1 or anti-BD1. So there is no brake of the car, there is no slowdown. The T cell or the immune system will go very fast to destroy the tumor cell. So this is in a very simple way, how can the checkpoint inhibitors work? So now we have many different applications of the checkpoint inhibitors, either for the solid tumors or for leukemia or lymphoma. So regarding the brain tumors, there is a clinical trial, which is a phase 2 clinical trial of using pembrolizumab for relapsed or refractory high-grade glioma or DIBG or hypermutated brain tumors, ependymoma or medulloblastoma, who recovered from the prior therapy. But till now, there is no definite result regarding this clinical trial. Also using checkpoint inhibitors against neuroblastoma, there is a phase 1 and phase 2 clinical trials of combined ipilimumab and nivolumab for treatment of relapsed refractory sarcoma in general. And this study includes also neuroblastoma. And there is only 2 partial response were achieved among 55 patients for this clinical trial. This is regarding using checkpoint inhibitors for neuroblastoma. Regarding the Wilms tumor, still there is no end result for this phase 2 clinical trial for the Wilms tumor using nivolumab or ipilimumab. Regarding sarcoma, or specifically for osteosarcoma, there is a clinical phase 2 clinical trial using avelumab as anti-BDL1 in adolescent with recurrent progressive osteosarcoma. But till now, there is no demonstrated activity for this study regarding the effect of the osteosarcoma. So, as we mentioned before, the major of the checkpoint inhibitors against the solid tumor, either brain tumor, neuroblastoma, different sarcoma, osteosarcoma. Till now, there is no solid response for these checkpoint inhibitors. But regarding the leukemia and lymphoma, there is a little bit improving or maybe a promising results. So using pembrolizumab in AML post-transplant in experimental arm, including 9 AML patients versus 18 control patient, we found that 100% survival at 100-day post-transplant in the experimental arm or experimental group using pembrolizumab versus 83% for the control arm not using pembrolizumab. So checkpoint inhibitors in AML post-transplant, it show a little bit promising results. Also regarding lymphoma, pembrolizumab was FDA approved for relapsed refractory Hodgkin lymphoma for adult and pediatric in March 2017. So it is around 15 patients with relapsed refractory Hodgkin lymphoma were included in the international study and 60% achieving response with pembrolizumab as a monotherapy. So this is the first part of the immunotherapy, which is the checkpoint inhibitors. Checkpoint inhibitors, we inhibit the brake of the car. We inhibit to make it very fast, directed against the tumor cells. The effect of the checkpoint inhibitors for the solid tumors still under clinical trials. Regarding lymphoma and leukemia, there is sometimes of checkpoint inhibitors FDA approved, and there is a promising results. So this is regarding the first section of the immune therapy, which is the checkpoint inhibitors. So what about the second type of the immune therapy, which is a T-cell transfer therapy, or as we know, it is a CAR T-cell. So the CAR T-cell, simply, we are taking the T-cells outside the body of the patients. We are genetically engineered specific receptor. We put this receptor on the surface of the T-cell, multiplying the T-cells to be many millions and thousands, and to be reinfused again. And this genetically engineered receptors on the surface of the T-cell has a specific affinity regarding a certain receptor on the tumor cells. That's why after infusion, the CAR T-cell go directly to the tumor cell to destroy it. So this is the idea behind the CAR T-cell therapy. So this is the structure of the genetically engineered receptors. It is composed of antigen recognition domain outside the surface, and there is a hinge region, which is the spacer, and there is a transmembrane domain to fix the receptor in the membrane of the T cell, and finally, the intracytoplasmic part, which is the intracytoplasmic T cell signaling domain. So this genetically engineered receptor, after genetically engineering it, it is embedded on the surface of the T cell, multiplying the T cell to millions of copies and reinfused again to be directed against the specific cancer in the body. Again, what about the clinical application of the CAR T cell in different diagnosis of solid tumors and leukemia lymphoma? This is an example of a paper published in 2021 in Journal of Immunocancer Therapy regarding using of the CAR T cell therapy targeting CD33 directed for the acute myeloid leukemia. And this study demonstrated a preclinical optimization of CD33 CAR T cell therapy in children and adolescent young adult with relapsed refractory AML. Also using CAR T cell therapy against B-cell ALL, but in this study, which is published in Blood in 2022, it is not only targeting one receptor, but it is targeting two receptors, CD19 and CD22. So this is to overcome a single antigen modulation. And as we mentioned before, there is an escape mechanism of the tumor cell to try to escape from the immune system. So sometimes by changing the receptor on the surface. So if I make a genetically engineered receptor of the CAR T cell targeting two receptors, not only one, so we can overcome this single antigen modulation. So this result showed a complete response rate in 20% of the patient, which is 12 patients out of 20. Cytokine release syndrome, which is a major side effect of the CAR T cell therapy, was recorded in only 50% of the patients. And 6 months, 12 months relapse-free survival was mentioned in 80% and 57% in this study. Also, we have an example of using CAR T cell therapy against T cell leukemia or lymphoma. So as we see here in this figure, this is a PET scan of the T cell lymphoma before starting treatment, and this is a PET scan of the same patient after using CAR T cell therapy against T cell. So it showed very good response. That's why the CD5 CAR T cell therapy are safe and can induce clinical responses in heavily treated patients with relapsed refractory CD5 positive T cell leukemia or lymphoma without inducing complete T cell aplasia. So this is using CAR T cell therapy in leukemia and lymphoma. What about the CAR T cell against the brain tumors? So this is an article published in 2022 demonstrating local-regional delivery of the CAR T-cell therapy for cerebrospinal fluid to treat metastatic medulloblastoma and ependymoma. And as we see in this picture, so the first pictures, this is a day 0, which is a disease before using the CAR T-cell therapy. After 1 month, we can find a very good response for this metastatic medulloblastoma or ependymoma. And at the end of the study, we can only find 2 pictures showed a recurrence, but the other picture showed complete remission, which is a very good and promising result of using CAR T-cell therapy against brain tumors. Neuroblastoma with CAR T-cell therapy. Neuroblastoma, this is our challenges in the last maybe 20, 30 years, because we are trying to use chemotherapy, transplant, either single transplant or tandem transplant, immunotherapy like monoclonal antibodies, anti-GD2, and also now we are trying to use CAR T-cell therapy against neuroblastoma and targeting different antigens. So in this study, which is the CAR T-cell therapy targeting different antigens against GBC2 or CD276. So targeting these multiple tumor-associated antigens against these specific receptors may overcome heterogeneous expression of a target antigens and identified a potent, clinically relevant CAR T-cell therapy against neuroblastoma. But till now, there is no definite results to conclude the final results about using a CAR T-cell therapy for neuroblastoma as a standard of care. Also, there is a CAR T-cell therapy targeting HER2 receptor for the advanced sarcoma, including osteosarcoma, rhabdomyosarcoma, Ewing sarcoma, and other types of sarcoma. And this study, which was done in Texas Children's Hospital, showed a good result that encouraged using of the CAR T-cell therapy for a chemo-refractory or relapsed synovial sarcoma. So now in details, we talked about checkpoint inhibitors and its application either for the solid tumors or leukemia lymphoma. Also, we talked about the CAR T-cell therapy and its application for solid tumors, leukemia, and lymphoma. Now the third type of the immune therapy, which is a monoclonal antibodies. So in a very simple way, the monoclonal antibodies is a different mechanism of the immune therapy. We are trying to create a specific proteins in the lab. This protein, like a Y shape, has 2 arms, one arm targeting a specific receptor on the tumor cells, and the other arm for connecting the T cells to target this cancer cell. So this arm, if a targeting specific receptor on the tumor cells, maybe CD20, CD22, CD19, whatever. So there is a many different monoclonal antibodies according to which target it can attach to it. So if our monoclonal antibodies targeting CD20, it is rituximab. So rituximab may be one of the first monoclonal antibodies which was approved in 1997 for adult and approved officially in pediatric just recently, a few years ago in 2021. And as you see in this graph, using of rituximab with chemotherapy had a superior event-free survival, better than using chemotherapy alone, and the other curve using of rituximab with chemotherapy has an overall survival better than the chemotherapy alone. So this is the monoclonal antibodies against CD20, which is rituximab. What about the monoclonal antibodies targeting CD33, which is GO, gemtuzumab ozogamicin? So it was approved in 2017 for adult and pediatric for more than 2 years. And recently it was approved in 2022 for pediatric more than 1 month. So this graph also is a little bit complicated graph, but it shows a very good and promising results of using gemtuzumab ozogamicin against the CD33, although it has a certain side effects like SOS or VOD, but a little bit in the recent few years after modification of the dose, we are trying to avoid this side effect. Another example of monoclonal antibodies targeting CD30, which is brentuximab. So it was approved in 2011 for adult and 2022 for pediatric. And here, this is a graph of event-free survival using brentuximab with chemotherapy has a better or superior event-free survival, better than the standard care. And also, this is a relapse rate. So it has a lower relapse rate of using brentuximab with chemotherapy, better than the standard care, which has a higher relapse rate. Monoclonal antibodies against CD19, which is blinatumomab. It was approved in 2014 for adult and 2018 for pediatric. And also, the blue arm of using blinatumomab has a better disease-free survival than the red arm, and the blue arm here has an overall survival better than the red arm without using blinatumomab. What about monoclonal antibodies against solid tumors? As we mentioned, solid tumors, the main challenging in the solid tumors is neuroblastoma. So this is dinutuximab, which is anti-GD2. So this dinutuximab was approved in 2015, but at the beginning, it should be combined with GM-CSF and interleukin-2 for the treatment of the pediatric patient with high-risk neuroblastoma. And it showed a good response rate and event-free survival of the immune therapy better than the standard chemotherapy. And this is event-free survival and overall survival. Also, the immune therapy has a higher overall survival rate better than the standard therapy. But the main issue of dinutuximab with GM-CSF and interleukin-2, it has a lot of toxicity. That's why there is another version of the dinutuximab, which is dinutuximab beta. So it was approved by European Medicine Agency in 2017, and it can be used alone without GM-CSF and without interleukin-2. And the results of this dinutuximab beta without GM-CSF and without interleukin-2 is very similar to the dinutuximab with the other medications. So we got the same results and we avoided the side effects. Now we have another anti-GD2 other than dinutuximab or dinutuximab beta, which is naxitumab. So this is another example of monoclonal antibodies against GD2. So what is the difference between naxitumab and dinutuximab or dinutuximab beta? So it is a humanized version. It has a 10-fold higher affinity than dinutuximab, and it was FDA approved in 2020. We can use GM-CSF with it, either with pediatric or lab or adult pediatric high-risk neuroblastoma, either for a minor response or a stable disease to standard chemotherapy, induction therapy. The final example of monoclonal antibodies against ERPP2, which is trastuzumab. So it was approved in 1998 against HER2 positive breast cancer. So in children, we don't have breast cancer, but the same receptor, which is HER2, maybe we can find this receptor in many tumors like osteosarcoma. But using monoclonal antibodies, trastuzumab, against HER2 receptor in the osteosarcoma patient, it didn't show any response. So trastuzumab didn't significantly improve survival when combined with the chemotherapy in metastatic osteosarcoma. Finally, bevacizumab, which is monoclonal antibodies targeting antivascular endothelial growth factor. It did not show significant benefit in rhabdomyosarcoma, osteosarcoma, or high-grade glioma, but there is an objective response observed in low-grade glioma and relapsed refractory high-risk neuroblastoma. So bevacizumab as a monoclonal antibodies against antivascular endothelial growth factor, still there is a question mark of using these monoclonal antibodies. Maybe there is a good response or a good results for low-grade glioma or refractory neuroblastoma, but there is no solid good results to use it as a standard of care. So now we finished 3 types of immunotherapy: checkpoint inhibitors, CAR T cell, monoclonal antibodies. Now, what about the treatment vaccine, which is a very common question we can face from our patients, from the families, from other members. The common question is there a specific vaccine I can receive it to protect me from against any cancer? The clear answer, no. But there is a trials and there is 2 FDA-approved vaccine can protect against a specific type of cancer. So this is the idea of the treatment vaccine. We can take a specific protein from the body, from the tumor cells, inject in the body, stimulate the immune system to make antibodies directed against this specific protein. So we can make a custom-made cancer treatment vaccine or universal cancer treatment vaccine, or I can use dendritic cell as a cancer treatment vaccine. And for example, this FDA-approved Sipuleucel T. And also there is an oncolytic viral therapy as a cancer treatment vaccine, which is also approved by FDA, which is called TVEC vaccine. What about the custom-made cancer treatment vaccine? So the immune system in this type of vaccine is directed against features that are unique to a specific cancer. So that's why it's called custom-made. And what about the universal cancer treatment vaccine? The vaccine is made from a tumor-associated antigen that are found on a cancer cell for many people, and that can be used as an immune response in any patients who has a cancer that produce the same antigen. So this is a custom-made and the universal cancer treatment vaccine. So what about this specific type of cancer vaccine, which is approved in FDA approved in 2010? So in this type of cancer vaccine, we are using the dendritic cell. So that's why it was dendritic cell vaccine that stimulate the immune system to respond to a specific antigen. So we can use this vaccine as an intravenous infusion to treat the metastatic cancer prostate, which is not responding to the hormonal therapy. So it was used as a second or salvage therapy for the metastatic cancer prostate as an IV injection. What is the other type of the cancer, of the treatment vaccine against cancer? So this type is oncolytic viral therapy, which is called TVEC vaccine. It was approved as oncolytic viral therapy from FDA. It based on herpes simplex virus type 1. It was injected directly into the tumor in case of skin melanoma that cannot be excised surgically. So the idea of the treatment vaccine, it is not general idea. There is no specific vaccine I can receive it to protect myself against the cancer, but there is a trial of creating a specific vaccine. 2 of them are actually FDA approved. One is using the dendritic cells, which can be used intravenous infusion against metastatic cancer prostate not responding to the hormonal therapy. And the second is oncolytic virus therapy based on the herpes simplex virus, injected directly into the skin melanoma, cannot be excised surgically. So this is the main 4 types of the immune therapy. The last item of the immune therapy, it is not a specific immune therapy, but it is a certain medications that has an extra action, which is enhancing the immune system. So if this medication enhances the immune system against the cancer therapy, that's why this group of medications called immune system modulator. So this immune system modulator enhances the body immune response against cancer. The effect can be specifically or generally on the immune system. So an example of the immune system modulator is cytokines, BCG, and immune modulatory drugs. So what about the cytokines? We have two examples of cytokines, interferons and interleukins. Interferon alpha can enhance the natural killer cell and dendritic cells. Also, it slows down the growth of the cancer cell and promote the apoptosis or promote the death. Also, the interleukin, like interleukin-2, it is a growth cell factor that boosts killer T cell and natural killer cell. Also, it helps B cell to produce a certain substance that can target cell. So these cytokines have a general enhancing effect on the immune system. That's why they are called immune system modulator. Another example of the immune system modulator, which is a BCG. I think all of us know many data regarding the BCG. So the BCG itself, it is a vaccine, but it is not, again, a vaccine against cancer cell. It is a vaccine against tuberculosis. And this vaccine contains weakened version of the bacteria called Mycobacterium bovis. So this is the primary action of the BVC. So the BVC has a primary action, which is vaccination against T tuberculosis. But it has a secondary action or extra action. We found that the BCG vaccine enhances the immune therapy, the immune system against the cancer cell. That's why it was considered as one of the immune system modulator. So the primary action of the BCG vaccine is tuberculosis vaccine, but an extra action is enhancing the immune system against the cancer cell. So how can we use a BCG vaccine as an immune system modulator? We can use it by inject the BCG directly through a catheter into the bladder in case of cancer bladder. So what is the effect of using BCG vaccine as an immune system modulator in cancer bladder? After injecting directly through a catheter, it can delay the growth and delay the spread of the cancer bladder into a deeper layer. So the BCG vaccine has an extra action other than the primary action against tuberculosis. It has an extra action if it is injected directly into the bladder, has a cancer, which is a slow growth of the cancer and prevent deepening of the cancer bladder into the deeper layers. This is another example of the immune system modulator. The last example of the immune system modulator is a certain medications like thalidomide, like lenalidomide, pomalidomide, or imiquimod. So all of them are angiogenesis inhibitor for the cancer cells, and the last one enhances the cell to release the cytokines. So all these medications has a primary action, and beside the primary action, it has another secondary action that it will inhibit the angiogenesis. That's why it enhances the immune system to fight against the cancer therapy. That's why they called immune system modulator. So this is the last example of the immune system modulator, immune system therapy. Now we finished the 5 main sections of the immune therapy. The first part is checkpoint inhibitors. The second part is CAR T-cell therapy. The third part, monoclonal antibodies. The fourth part is treatment vaccine. The fifth part is immune system modulator. All of them under the umbrella of the immune therapy. So this is the last slide, which is, I think, we can talk about these items many hours, but in brief, there is different way to improve the efficacy of the immune therapy. Maybe we can overcome the resistance. Maybe we need a better assessment of this immune therapy. We need to overcome the mechanism by which the cancer cell suppresses the immune response. And finally, which is a very very obstacle of using immunotherapy is the side effect. If we minimize the side effect as much as we can, this is a very good challenge to improve the efficacy of the immunotherapy. So now I'm done. Thank you so much. And thank you for the organizer. And this is our National Cancer Institute in Cairo, the old campus and the new campus. Thank you. And I'm ready for any question for you. Thank you.
Thank you, Professor Yasser, for this informative lecture that helped us to understand more about the different types of immunotherapy. Please, if you have any question, raise your hand or write it in the chat box.
So if there's no any questions, that mean either you understand everything or you don't understand everything. So maybe the first option. I will be very frustrated if it is the second option.
Someone is asking about the sharing the presentation.
Yeah,
The lecture.
I will send it to you so you can send it to anybody. I don't care.
Okay.
Okay.
The lectures all will be recorded and posted soon on the YouTube channel of the site. Someone is asking about combining different types of immunomodulators therapy in cancers would lower the possibility of remission of cancer.
Actually, the combination between the different types of immune therapy is still under clinical trials because we don't have a solid data regarding a monotherapy. So make it a combination is still under clinical trials. There is many examples. I cannot present all the ongoing trials in the short presentation. But till now, there is a many trials regarding either monotherapy or double agent therapy, maybe double agent with the same mechanism of action, or maybe double agent with different mechanism of action. So the idea is, okay, it is applicable, but there is no solid result to be standard of care.
Okay. Dr. Jovan is asking that immunotherapy is a type of targeted therapy. Would you comment about other target therapies?
The target therapy, immune therapy can be considered target therapy. Checkpoint inhibitors can be considered target therapy. Also, CAR T cell is a target of cancer, target therapy. So the target therapy is a general expression, maybe include different types of the immune therapy. In any medications targeting a specific receptor can be considered as a target therapy. So monoclonal antibodies is a target, CAR T cell therapy is a target therapy, and different types, if it is targeting a specific receptor, it will be considered target therapy.
Okay, thank you all for joining us. Just a gentle reminder to fulfill the form sent in the chat box to be eligible to take your certificates. But we have one more question. Um No, it's not a question. It's a comment that Dr. Christine